I'm going to anchor in NG, so I would go into the room, check the patient's name, and ask them their name, date of birth. I then, before going in, I would already check to see the doctor's order was put in for it. I would explain the procedure to the patient, ask if they had any questions, and then I would close the curtain for privacy, wash my hands. After I wash my hands, I would then first check, ask the patient about their nasal history. I would check for any obstructions. I would check the patency. I'd ask him to breathe in and out of the nose. And then the best one, with the higher airflow, is the nasal I would be going into. Then I would measure from the tip of the nose to the bottom of the earlobe to the side. I would process, and I would mark it so I know where to stop at. I'd put a chuck over my patient, raise the bed so I don't break my back, and then I would raise the head of the bed to the high Fowler's position, 60 to 90 degrees. Also, I'd make sure that the patient is aware enough that he can handle the procedure. I would lube my NG, easier to go down. But first, I put my gloves on. Sorry, in real life I'd put them on. After it's set in the lube and ready to go, and I'm going in the right, I would instruct the patient that as I'm going in to keep swallowing the drinking water, he'd have that in his hand. I'd hyperextend the head, telling deep breath, and then to keep swallowing. Swallow, swallow, swallow. I would keep going, and if I would hit any resistance, I just turn, and I'm at my mark. I would inject 50 milliliters of air. I want to hear swooshing in his stomach, and I know I'm in the right place. And then to make sure I'm in the gastric area, I'd pull back because I would want to see gastric juices, and then I would put the gastric juices back in because I don't want to. I want to restore his electrolytes. I don't want to put him off any. And then wipe the top of his nose off because that nose gets oily. I would then tape it. I'd split it down the middle, and then over his nose, put these around. I really want to anchor it to his nose so it doesn't, so if he tugs on it, it doesn't come out. I don't want to block his nasal airway either. Pull on it to make sure it's good, and it's good. Give him a tissue if he needed it, and then I would secure it. I don't want to secure it too tightly. I want to give him a little bit of leeway. And then safety pin it to his shirt. put the bed back to the way it was, ask the patient if he needed anything. I would then document the nasal area that I put it in, how the patient tolerated the procedure, and if it was hooked up to suction. And then I would then set up a daily care plan for the patient of when we're going to do nasal care. I'd also want to do oral care too. And then when he's ready, I would check the doctor's order to make sure if we're really pulling the NG, and if we are, I would cap it off for 30 minutes to an hour to make sure that the patient doesn't have any nausea or vomiting, because if he did, then the doctor would need to be called. And then when I'm ready, I'd raise the bed back up, had the bed still raised. Of course, I'd introduce myself because this is the second time I'm meeting him. Check his armband, wash my hands, re-put on my gloves, and then I would unsafety pin him. I would make sure that the curtain is pulled to give my patient his privacy. I would untape it. Then have some tissues close by. Pinch the tube off, because as I'm pulling out, I'm going to pull out and I don't want any of the gastric juices to aspirate in his lungs. I tell him to take a deep breath in and hold it until I pull it out, and then I would remove it. I'd put it in a bag, a clear bag, and waste of it. I'd wipe his nose off, tell him to blow the nose if possible. Then I would lower the bed back to the position it was in, ask the patient if he needed anything, document how the patient tolerated me pulling out the NG, and then the time and the date that I did it to. And that's it.